Assalamu alaikum. I'm Dr. Waqar Haider, and today my topic of presentation is urological consideration in pregnancy. In this topic, we will discuss the physiological hydronephrosis in pregnancy, imaging in pregnancy, general concept of surgical management in pregnancy, and general concept of urological medication in pregnancy. So, physiological hydronephrosis in pregnancy, a comprehensive review of management strategies, diagnostic challenges. So, anybody here, Dr. Hamad, can you tell us what is hydronephrosis?
Hydronephrosis is the collection of pelvic seal system dilatation due to obstruction of outflow of the pelvic seal system, leading to collection of urine within the system.
Exactly. And dilatation and distension of renal collecting system on both are one or both kidney due to obstruction of urine outflow distal to the renal pelvis. And here the classification, we can classify hydronephrosis into 4 grades according to SFU classification. In SFU1, sinuses are open. SFU2A, intrarenal pelvis dilatation occurred. In SFU2B, external pelvis dilated, major calyceal dilated, and in SFU3, minor calyceal also dilated. And in SFU4, along with all, there will be a parenchymal thinning. So, what is hydronephrosis in pregnancy? We can classify this into two class. First, physiological hydronephrosis, where it could be because of result of pregnancy-related changes, but it can also pathological, in which obstruction of kidney due to stone or other pathology like tumor occur. So, why it is important to diagnose? So we must differentiate physiological hydronephrosis from pathological because it's crucial to and its impact on treatment approach. The condition can present with symptoms like flank pain, nausea, or discomfort, which may overlap with other serious conditions such as renal colic or infection. A study
So basically, we have to differentiate the physiological hydronephrosis in pregnancy from the pathological hydronephrosis because in pregnancy, as you know, that there these symptoms which are more commonly seen in renal colics or ureter colic are already present because of the progesterone or hormones or pregnancy related factors like flank pain, lower abdominal pain, vomiting, nausea, decreased appetite. So the history in pregnancy related to the renal stone or ureteric stone is vague. So one must know when to go for the investigation and when to treat the hydronephrosis or the symptoms which is causing the hydronephrosis on the basis of investigation and other findings.
And a study by Fennery et al. 2000, out of 30,552 women delivering at a single institute, only 56, about 0.2%, were admitted due to symptomatic hydronephrosis. So physiological hydronephrosis is seen in 80% of pregnancy, particularly during the third trimester. Here's the mechanism. First, the hormonal influence. The progesterone causes relaxation of smooth muscle in the uterus, leading to decreased peristalsis and uteral dilatation, and also a mechanical compression of enlarging uterus that physically compress the ureter, particularly on the right side, due to the dextrorotative position of the uterus and its weight. Symptomatic hydronephrosis. Some women may experience mild to moderate flank pain, often intermittent. Non-specific symptom like nausea, vomiting, or discomfort may also occur. Symptom tends to resolve after delivery in 6 weeks. The investigation done for this are first we should go for non-ionizing and investigation, in which ultrasound is the first line imaging and most commonly used diagnostic tool for identify hydronephrosis during pregnancy. It is non-invasive and does not expose the fetus to the radiation. Other imaging modalities are CT scan are generally avoided due to radiation risk unless complications such as obstruction or infection. MRI may be useful in complex cases for detailed anatomy, especially in the later stage of pregnancy. Pain level and hydronephrosis grade may not align, make clinical management based on symptom alone unreliable. So hydronephrosis management, first we should go for conservative management, in which good hydration, positioning the patient to the left lateral decubitus position or lying sideline position can elevate pressure on the uterus, improving drainage and reduce discomfort. Pain management, mild analgesic like acetaminophen can be used for pain relief and generally avoided during pregnancy. And serial ultrasound to monitor the progression of hydronephrosis. If symptom worsen or sign of infection appear, further intervention may be necessary. Here when we consider intervention in hydronephrosis in pregnancy, Persistent pain, unresponsive to conservative measures, sign infection, fever, chill, or elevated WBC count or pyelonephritis, severe symptom like nausea, vomiting due to discomfort, renal impaired patient is in renal failure secondary to obstructed kidney, glacial rupture when patient have ruptured kidney or develop perinephric collection or urinoma, postpartum hydronephrosis if it does not resolve after 6 weeks of delivery and symptom persist due to secondary causes like ureteric stricture, external compression, etc. Here, the surgical management of the hydronephrosis, uteral stent indicated in use for moderate to severe hydronephrosis when conservative measure fail. Stenting may be considered when pain and or complications significantly impair quality of life. Those that provide symptomatic relief from moderate to severe hydronephrosis and Gonza and cause discomfort from stent, potential for incrustation, calcium deposit. As you know, the pregnancy is a hypercalciuria state due to progesterone effect, so it can cause incrustation and urinary tract infection. PCN, we can do PCN, but it is rarely used and reserved for refractory cases and when stenting fail. Risk are a higher complication rate, including infection, discomfort, and catheter-related issue. This approach is typically avoided unless absolutely necessary. These are the risk: anesthesia-related complication, fetal loss, teratogenic effects, sepsis, nephron loss, and mortality. The second topic is imaging role in pregnancy. Essential for acute condition like kidney stone, acute abdomen trauma, and malignancy. Risk of fetal radiation exposure. Radiation can cause teratogenesis, development anomalies, carcinogenesis, increased lifetime risk, cancer risk, mutagenesis, DNA damage passes to future generation. The goal is to balance diagnostic need with fetal safety guided by American College of Obstetrician and Gynecologists recommendation. So in the first trimester, as you know, the organogenesis occurred in first trimester, so there will be a risk of malformation or functional defect. In second trimester, as the organogenesis already occurred, so there's a decreased teratogenic sensitivity but increased risk of certain cancer like childhood leukemia and other malignancy. Both gestation age and dose amount affect the risk level for the fetus. Safe dose of radiation. The fetus radiation dose below 50 milligray is considered safe and not cause any harm. According to Center of Disease Control, radiation dose between 50 milligray to 100 milligray is regarded inconclusive in terms of impact on the fetus. So here is the chart. We can see that death of embryo occur if we increase the estimated threshold, which is between 50 to 100 milligray in the period of 0 to 2 weeks, that is before implantation. And if the estimated threshold of radiation increase from 200 to 250 milligray, congenital anomalies like skeleton, eye, and genitalia and growth restriction occur in 2 week to 8 week after fertilization, which organogenesis occurred. And if we increase the estimated threshold in 8 to 15 weeks, where intellectual disabilities, intellectual deficit, and microcephaly occur in the 16 to 25 week period. If we increase threshold from 280 milligray, severe intellectual disability. These are the radiation doses for different investigations. CT abdomen pelvis, it is 10 millisievert, and without contrast, CT abdomen pelvis with contrast 20 millisievert, intravenous pyelogram 3 millisievert, X-ray plane 0.001 millisievert, and CT chest 7 millisievert, and DEXA scan 0.001 millisievert, PET scan 25 millisievert, and mammography 0.4 millisievert. The American College of Obstetrician and Gynecology guideline for imaging in pregnancy, which lies imaging approach, minimal risk for malformation, coordination with radiologists help reduce unnecessary exposure by adjusting techniques, use low dose protocol, minimize scanning time and shielding if possible. The LARA protocol use LARA is as low as reasonably achievable. First time radiation of time of exposure can directly reduce the radiation exposure and reduce radiation dose by doubling the distance between your body and the source of the radiation. And the shielding lead equivalent shield for X-ray and gamma rays is an effective way to reduce radiation exposure. And the question is, ultrasound is safe in pregnancy? So theoretically, ultrasound, especially Doppler, increase the fetal temperature up to 2 degrees centigrade. But according to document, there is no fetal adverse effect of ultrasound. Peripheral imaging multi in pregnancy, ultrasound and MRI. Ultrasound is safe and widely accessible and preferred first-line imaging. MRI, non-ionizing radiation, safe alternative, and ultrasound is inconclusive. Usage is prudent use to address the clinical question, directly aid in patient care, minimize fetal exposure while providing essential information. Secondary imaging options are radiography and CT, sometimes necessary for detailed imaging of obstructive pathology and trauma. Dose management is technique like fetal shielding, limited exposure area, reduce fetal dose. If ultrasound or MRI is unavailable or insufficient, these modality can be used safely with SIUT dose recommendation. MRI recommended for cases needing detailed soft tissue assessment without radiation. So gadolinium-based contrast is restricted due to potential risk, administered only if significantly improved diagnosis and positive impact on maternal and fetal health. Nuclear medicine, renal imaging, technetium-99, commonly used for assessing renal function in pregnancy. Its benefit as its low dose gamma rays, minimal exposure less than 5 milligray, and short half-life of 6 or reduce residual exposure. It provides information on renal function and drainage crucial for urological condition. Intraoperative fluoroscopy. Fluoroscopy may be needed for procedure like uterine stent placement. We can minimize the radiation by protecting the fetus from use of shield to protect the fetus from scattered radiation, collimation, limited exposure only to necessary area, low dose spot film, reduce the number of images taken while confirming placement. Best practice is to limit fluoroscopy to essential views, avoid excessive imaging. The general concept of surgical management in the pregnant patient. Interdisciplinary collaboration between surgeon, anesthesia team, and OT staff and obstetrician, fetal monitoring, maternal position, and timing of intervention. SIUT recommendation for non-obstructive surgery. First, the safe anesthesia. Standard anesthetic agent currently in use do not show teratogenic effect in human, provided they are used in safe concentration and duration. Fetal heart rate monitoring. Fetal monitoring assist in ensuring maternal fetal safety, detecting distress, and managing anesthesia responses. Adjustment based on fetal heart rate monitoring can aid in positioning and cardiorespiratory management. Indicated surgery. Essential procedure should not be delayed due to pregnancy. Clinical indicated surgery proceed regardless of trimester if medically necessary. Essential versus elective surgeries. Elective surgery should be deferred until after delivery to minimize risk to both mother and fetus. Second trimester is optimal due to low likelihood of preterm and spontaneous abortion. Increased safety with stable maternal physiology and less pressure from the small uterus on the other organ and blood vessels. So tertiary care system should be available for hospital with neonatal and pediatric capability are preferred to manage any potential complication. Surgeon should ensure that obstetric provider with cesarean delivery privilege is readily available, and fetal heart rate monitoring should be interrupted by a skilled professional to assist in timely clinical decisions.
So, if the surgery or the intervention is necessary, right? We have already discussed what are the indications for urgent or imminent surgical intervention in pregnancy. So, it should be done in a setting where pediatric and nursery facility is available, and especially the anesthesia time is saved in the second half of the second trimester, because we have already discussed that the teratogenic effect and the risk of premature labor is minimum in the second half of the second trimester.
Ethical consideration, patient autonomy. SIUT guidelines stress the importance of respecting maternal autonomy in decision making. Pregnant patients have a right to make informed decision about undergoing necessary procedure. There should be a comprehensive counseling between physician and the patient, and balanced information regarding risk and benefit to both mother and fetus should be provided. Important to recognize limitation in current knowledge on some maternal fetal outcome, especially in complex cases. Positioning of surgery, avoiding inferior vena cava compression. The enlarged uterus can compress the IVC, potentially reducing blood flow and affecting venous return. So the best position is left lateral decubitus position, and this position helps to optimize circulatory stability and prevent hypotension. This position is especially critical in open and laparoscopic surgery to protect both maternal and fetal hemodynamics. Comparison between laparoscopic and open surgery. Available data suggests that both methods have comparable maternal and fetal outcome when used with care. Minor risk associated with low birth weight and preterm delivery observed more with laparoscopic procedures. Society of American gastrointestinal and endoscopic surgeon recommendation that safe insufflation pressure range between 10 to 15 millimeter mercury, avoiding higher pressure that cause maternal cardiovascular changes, and tidal capnography can monitor maternal carbon dioxide level to ensure that respiratory physiology is unaffected by insufflation pressure. The most risk perinatal mortality and preterm labor risk, most risks are due to underlying maternal condition, not necessarily the surgery. A noted 16% of preterm labor with third trimester general surgery is emphasizing caution. Utoscopic procedure during the third trimester have a higher than usual preterm labor rate, especially at around 10%. General concept of urological medication administration during pregnancy. So FDA label change in 2015. Before that, there was an old system that explained the risk by alphabetical categorization. Category A, no risk to fetus in human study. Category B, no risk to fetus in animal study, but no adequate or well-controlled study in pregnant women. In category C, risk to fetus cannot be ruled out, but potential benefit may outweigh the risk. Category D, positive evidence of risk to the fetus, but potential benefit may outweigh the risk. In category X, contraindicated in pregnant women. So FDA changed this system in 2015 because it is easy to categorize, but it did not provide sufficient information. So new FDA labeling requirement replace categories, provide a more nuanced view of risk and benefit. Label content must now include a summary of risk during pregnancy and lactation, discussion of available data supporting the summary, and guidance for health provider to support clinical decision making. This new system required healthcare provider to evaluate evidence-based data, moving away from general classification system. Labeling requirements, every drug in his box have a proper labeling required summary detailed that each label provides specific information on risk, safety, and data for better informed prescribing. Since label are now data focused rather than categorical, provide need to interpret detailed risk summary to personalize medication choice. Role of urologist in obstetrician collaboration, importance to ensure maternal and fetal well-being, minimize potential side effect of drug. Emphasize that urologists must often rely on evidence and data interpretation, as many urological drugs have limited pregnancy safety profile. Encourage multidisciplinary team work for safe patient-centered decision. So these antibiotic are indicated and contraindicated in pregnancy, safe in pregnancy are cephalosporin, penicillin, clindamycin, and gentamicin. Contraindicated in pregnancies are quinolones, tetracycline, and streptomycin. Metronidazole should be avoided during first trimester in pregnancy, and the third and second trimester sulfonamide and nitrofurantoin are contraindicated. On a botulinum toxin in urology, explain the widespread use of Botox for neurogenic and idiopathic lower unit X symptom due to its effective symptom control and low compliance rate. Animal studies indicate potential fetal harm when Botox is administered at high dose, which may impact fetal weight and development. Manufacturer advise usage only if benefit outweigh risk, especially due to finding of reduced fetal body weight and maternal and fetal complication at high doses. Thank you.